Equine limb radiography. Today we will be discussing a case where radiography is used as a diagnostic tool in equine medicine. So this case is about Summer, an 18-year-old POA mare who presented for acute onset of lameness noticed this morning. The owner found a nail penetrating the frog from the front left hoof and called the clinic right away. The receptionist advised the owner to not remove the nail and to keep the horse still and calm. The veterinarian was scheduled to arrive in the next 30 minutes. The veterinarian performed a quick physical exam and noted a 5 out of 5 grade lameness due to the nail penetrating the frog of the left front hoof. Summer also had increased digital pulse in the limb and was very sensitive to touch. All her other body systems were within normal limits at this time. So the issues with puncture wounds is that the most concerning aspect of puncture wounds is the nail could penetrate and damage important structures in the hoof. Some of these structures include the navicular bursa, navicular bone, coffin joint, deep digital flexor tendon, and even the third phalanx. A rapid diagnosis and treatment is important. Radiographs will identify which structures are affected. The equipment used for field radiography is a portable radiograph machine, film cassettes, a cassette holder, and a wood block. The wood block is used to raise the foot into the center of the primary beam. 3 staff members are also ideal to assist in taking x-rays. One person to hold and restrain the horse, another person to operate the radiograph machine, and the third person holding the cassette. So there is a difference between portable and stationary machines. So the different type of radiograph machines in veterinary medicine are the portable machine, which most are common in equine medicine. These machines can be taken on farm calls, but are limited to thinner body parts like extremities. This is due to a limited penetrating power. The source image distance for these portable machines are shorter, only being 26 to 30 inches. Which helps to shorten the exposure time. There can be some inconsistencies in exposure due to varied line voltage. It is also very important to wear your personal protective equipment because exposing others to the primary beam is a higher risk. Portable machines also are not very forgiving when it comes to patient movement due to its low MA capability. Stationary machines, on the other hand, are more common in small animal medicine and specialty equine practices. Therefore, owners have to be able to transport the patient, and the cost of diagnostic imaging is usually more expensive in equine medicine. The source image distance is longer at 40 inches, and they have shorter exposure times. Like I said, personal protective equipment is very important, so all staff members should protect themselves from radiation. Establishing a standard that everyone must wear lead aprons, thyroid shields, and gloves is the best practice. A dosimeter badge also needs to be worn to monitor the amount of radiation that's exposed each individual. Horse owners must be instructed to stand away from the imaging area. So in order to prepare for radiographs, because Summer was very painful and stressed, she was given a light sedative for this procedure. A digital nerve block in the affected area was also administered. The hoof was cleaned to remove dirt, bedding, and gravel. It is also recommended to remove the shoes, but Summer was not shod. Deep grooves of the sole are filled with Play-Doh to prevent dark air artifacts in image. So when positioning for x-rays, the dorsal palmar view and the lateral medial view are most common. These were taken with Summer and were diagnostic in this instance. In some cases, oblique views are required because the lateral medial and dorsal palmar views or plantar views are evaluated and only does 50% of the limb. To obtain these views, the beam is angled to the mid-sagittal planes of the limb. Here are the images of Summer's lateral medial x-rays. I have also provided an image of the hoof anatomy for comparison. As you can see, the nail penetrated about 1 inch into the sole. Likely, deeper structures are not affected. The nail was removed, and the penetrating tract was lavaged with an antiseptic solution. Once dry, the hoof was bandaged, and the bottom protected with duct tape. A tetanus vaccine was also administered because the patient had not received this vaccine within the last 12 months. A penicillin injection and a short-acting pain and anti-inflammatory drug was also administered. Long-term pain medication is contraindicated because it can mask synovial or joint infections if they develop. The owner is also instructed to keep Summer in a clean, dry stall. She can be hand-walked 3 to 4 times a day for short periods. The owner is to replace the bandage if it becomes dirty, damaged, or wet. The vet will return in 7 days to recheck Summer. The prognosis of puncture wounds of the hoof is dependent on depth, duration, and damage. A good prognosis is expected if no infection is present or if it is confined to the hoof wall, and the nail penetrated only superficial structures and immediate treatment is completed. A fair to grave prognosis is foreseen if the infection develops below the sole of the hoof, and in extreme cases, also the joint, which can occur if treatment is delayed. If deeper structures of the hoof are damaged, emergency surgery may be required. So cases like Summer can be prevented by routinely sweeping paddocks, barns, and pastures to pick up any loose nails and nettle. Also make sure that your farrier is picking up his nails after they are removed. So Summer's prognosis is good because no deep structures were penetrated and treatment was immediately initiated. This was also helpful that the owner did not remove the nail prior to veterinary arrival. The veterinarian believes that Summer can go back to work in 10 to 14 days.